Dr. Fabio from Arizona.
Thank you for having me.
Yeah, we got a lot to cover. We're going to talk about NAD and a lot of what makes it such an interesting thing at this place and time in our lives. And that's kind of how we got connected. So tell us a little bit about what drew you into your profession. Like what drew you, makes you passionate about what you do daily for people, and tell people about that.
Sure. So I'm a bit of an odd duck in medicine, kind of a varied background. I'm board certified in multiple different specialties, but primarily I started off as a nuclear medicine molecular imaging specialist. So I have a background in nuclear physics and predominantly in imaging using radionuclides for functional imaging, physiologic imaging, and it's something that's the mainstay in cancer. I spent a fair amount of my career doing that in the academic world with research and with multiple imaging clinics. In particular, it's just kind of I'm going to give you a little background that transitions into, why we're passionate about NAD. In the oncology world, I did a lot of work in early imaging with PET imaging and prostate cancer with a specific type of imaging called PSMA imaging. And that's was a focus of my research for a couple of decades. When I was at the University of Arizona, we kind of transitioned that research protocol into somewhat of a concierge oncology practice. And so we were taking care of a lot of cancer patients across the board that we were discovering things on these imaging studies that basically standard of care didn't know how to handle. So we kind of became the primary care folks for people. As part of my continuing educational background, I did a fellowship in integrative medicine, which was also at the University of Arizona. I'm also trained as a bariatric obesity medicine physician. I have a background in culinary nutrition, being able to really understand how nutrition affects things. And all of this has really been, initially was focused to really helping our cancer patients thrive. Okay. So for the last decade or so, we really became adult medicine, primary care, integrative medicine, longevity medicine type of clinic. We still manage a lot of cancer patients. I see new cancer patients all the time to really help manage their care. But our primary focus has really been on all the things that standard of care is not able to provide. So we guide people through standard of care, but we know that there's some limitations on what that has to offer, either in being able to deal with the issues, but particularly with side effects, quality of life, and longevity. And so we've really kind of fill in the gaps for a lot of folks in the cancer world. And as part of it too, then I see people who are just interested in longevity with no cancer, so adult medicine. So what we bring to the table is a lot of tools that are, again, standard of care, but all the other things that are in the complementary and kind of an alternative world, whether it's supplements or off-label medications, those kind of things. What is interesting in the longevity kind of world right now, we look at the different medications or supplements and things that are kind of keen interest that are being studied right now. A lot of these came from the cancer or oncology world.
Yeah.
So things like low-dose naltrexone and rapamycin, metformin, which is actually a diabetes drug, but our
Yeah.
experience and how they work for cancer and the transitioning to kind of longevity or anti-aging, because probably the underlying mechanisms for which they might help for cancer are going to make us do better all overall. But so it's an area where we bring a lot, kind of a deep area of expertise into it and a lot of comfort in dealing with these medications because we've worked with them for a long period of time. So that's a little bit of kind of how we arrive where we are. But in particular, with a molecule like NAD, and we can talk at some point a little bit about the specifics of mechanism and things like that for the NAD of how and why it's important. But NAD is a coenzyme that we found basically to be extremely useful in our cancer patients who were having issues with cognitive dysfunction, brain fog, fatigue, after
Were these
chemotherapy
side effects of the treatments for the cancer or the cancer itself?
from the treatment.
Okay.
Predominantly, well, some cancers will cause them, but a lot of therapies that we use for cancer actually cause oxidative stress. They cause, a certain amount of cellular damage, and we're purposefully doing that to the cancer cells, but
Right.
unfortunately, it affects all the cells in the body, right?
Yeah.
We see collateral damage. Brain fog is a real classic side effect that happens across the board in a lot of therapies that are significant. So chemotherapy, for example, in women with breast cancer, with hormone deprivation, we take the estrogens away, we use certain medications for that. Or men with prostate cancer, where we use androgen deprivation therapy, reducing testosterone. Maybe some different mechanisms on them we don't fully understand, but people basically don't feel well with them. And cognitive dysfunction, brain fog, as most people describe it, is something that is really common. And we have a terminology for it, chemotherapy-induced cognitive dysfunction. So it's a known entity. So we began using NAD IV therapy as part of our regimen to combat that actually many years ago, based on our understanding of how NAD works and translating it from use in things like post-Lyme's disease, chronic fatigue syndrome. And we had a lot of success with it. So it became part of our regimen to use high-dose NAD IV in those circumstances, and very useful. So it's probably going back a decade for us. The challenge, I think, on NAD, at least the way it's currently available, I'm sure your listeners who are familiar with NAD have heard about NAD IV. I think there's a lot of different clinics who are providing NAD IV right now. I think the challenge with it is done correctly, there's a fair amount of obstacles or challenges with it. It's when you deliver a bolus or high dose of IV NAD, if you give it too quickly, we can get a lot of side effects, and this can be very uncomfortable for people. So to do it correctly,
Yeah, I mean,
it's given
the
over
things
time.
that I hear or read about is that it's very time intensive, right? Because it's like 3 hours. It's also fiscally, it's a very big investment.
Expensive,
Yeah.
right?
And
Yeah,
you said too much, too quick can have some side effects.
right. So our protocol for our cancer patients is 4 to 5 days sequentially of 250 to 500 milligrams. We try to achieve 3 grams in a week. And it's challenging. It's 3 hours to 4 hours in the IV chair. Now, we have a very comfortable situation here. We make it nice, but
Yeah.
it's a long commitment. It's an IV every day. And because of the resources and the expense of it, it can be expensive. And typically out there, I see IV clinics charging $500 to $1,000 per IV. So
I
it's
I
not
can vouch
really,
1,000's what I've seen. Yeah.
yeah. So in the situation where I'm dealing with someone who has a profound fatigue, brain fog, whatnot from a treatment, doing something like that makes sense because we move the needle very quickly on it. But translating that into the wellness or longevity world, where I'm not dealing with that kind of level of brain fog, but I want to improve my level of cognitive thinking, energy, sports performance, make my DNA basically repair mechanisms better. That is not a sustainable process as far as basically going in and getting an IV. NAD naturally declines in our bodies, and if we're replacing it, it is a coenzyme that's used in probably 50% of our enzymatic processes at the cellular level. It powers our mitochondria for ATP production. It's part of the machinery, the molecular machinery of how we function. And you don't just raise it back up and it stays there. Unfortunately, as we get older, our ability to make our own NAD for that process goes down. So you need a mechanism by which you have a plan of like, well, if I'm going to start NAD, I need to be able to continue NAD.
Right.
And particularly for those who really get a lot of palpable benefits from it, they're looking for how do we do this? So that was really early on a challenge for us. And particularly as we were looking at providing NAD for other clients who we knew would benefit from it from a longevity perspective, from a cognitive perspective. How do we do this without basically going the route of monthly or quarterly IV therapy? And this is where we moved into going into subcutaneous administration. And that's something that really only has been around for the last few years, probably about 4, where we were able to have formulations that could be done subcutaneously.
Yeah.
And that is something we started doing for our clientele almost right away. And it evolved into something where, initially we were drawing a lot of syringes, preparing the needles. We're a concierge practice and try to do as much for our clients to make it easy as possible. And we realized that even with going to subcutaneous injections where people could do them more frequently, we could teach them how to do it at home. Still some challenges on, dealing with needles, dealing with syringes, dealing with vials. proper dosing, all of those components on it. And so we created a system by where we incorporated all of this into a pen injection to make it really easy. And that's been very successful for our clientele. The idea has been to minimize the muss and fuss with it. And I have clients aged 45 to, I think my oldest patient's 89,
Wow.
who basically is able to self-administer their NAD. I think that's part of this process is anything we want to do,
Yeah, it's
it
reviewed
needs to
here.
be
You,
sustainable.
the background in cancer prevention or treatment, you sort of migrated into this as a byproduct of helping people recover from the collateral damage of the cancer treatments. And now you're finding that it has a lot of use. And I tend, the term longevity, I'm not anti longevity, but in a lot of cases, we're not talking about longevity. We're talking about optimal life, which is, I
Mhm.
consider to be different from living as long as you possibly can. But
Yeah.
I think about is enjoying or being more, enjoying your days more, you could
Yeah.
say.
Yeah, I think
So
we're trying to use the word health span. I think now is the word that
health
might
span,
be trying
yeah,
to
I
describe
have
that.
heard
We
that.
want to
I
be
have heard that term.
healthy for as long as possible.
Yeah,
Absolutely.
absolutely. So what I'd like to do is sort of quiz you a little bit about when someone, let's say that they are looking into NAD injections, tell us what type of experience, and we're talking about, you were talking about the IVs aren't the most sustainable thing in terms of either cost or time or convenience. Tell us what someone should expect to, I mean, I'm 48, so give me an idea of what someone like me would expect if we're pretty athletic and we want to investigate NAD injections. What would they feel? What would they, what roughly would it cost for, say, to try out the treatment for a month or two?
Mhm. Yeah. So the idea for us was to be able to provide sufficient NAD that for the vast majority of people, they're actually going to have a palpable sensation that, yes, things are, they can tell that they're on the NAD. Okay. Which is one of the things that differentiates it, I think, from a lot of other longevity things that we talk about out there where we don't have measurable or objective evidence that they're doing anything. We maybe at the cellular level. So for us, the goal was to be able to provide convenient access to at least 1,000 milligrams per month. And some people react to less than that, but that's what we found has been the dosing that across the board people respond to the most. The idea with that then is to be able to split that into multiple injections through the month, usually 2 times per week, not sequential days, but that's
Correct
kind
me
of where
here.
we
This
start.
is this is a podcast host, not a doctor. What we're doing when we take the NAD is we're actually increasing our NAD levels, right? And the benefit of the IV is it increases those levels dramatically, very quickly, but then it drops off. And so what we're doing by having those injections 2 times a week, we're basically keeping those levels at a moderate amount, depending on how much we inject.
That is correct. So anytime we do a bolus or large injection,
Mhm.
we're going to have like a peak amount of it. And yeah, the idea is to replace that NAD, the NAD pool. And NAD basically gets metabolized up. It gets into the cells. It gets into the mitochondria, the powerhouses of the cells, and is used for ATP production, basically the energy systems of our cells.
So my question there
Now,
is, if someone is very, very physical and they're training, say, an hour and a half a day, an hour a day, do they use those stores up more quickly than someone who's just a brisk walker?
so exercise in and of itself increases our NAD production. Our own NAD mechanisms will ramp up with that. But strenuous activity or significant resistance training or endurance training, we will deplete that NAD at a faster level. When we do measurements of particularly athletes, we can see where the NAD levels are, and we'll see particularly post-competition, real significant effort provided that there's a significant dip in the NAD. Athletes do tend to generate more of it from the concept of doing exercise. They will have a recovery of that to a certain extent. So there's an advantage to that, which is always why natural ways of getting your NAD up are great. But what we find is then being able to replace that more consistently, we see recovery times after exercise basically reduce. We see higher energy levels in that exercise. We see higher performance. We're helping your body not end up in that depleted situation. This is where being able to do it with more frequent, smaller doses of the NAD, self-injection at home, that's really where I think people find that it has the most utility and is the most convenient way to do it. Part of it too is that from a timing perspective, if you're going to go for an IV, is it going to be in sequence with when I just did my exercise, or can you time that properly?
Yeah.
With home IT, well, I've finished my exercise and rest a little bit, and you can give yourself a boost of it. So the ability to really keep the NADs or get the NADs up to a higher level and maintain them, you really need to have something like the system. Now, the NAD basically, there's multiple different formats for which it comes in, or at least administration. IV is really where it all started. It's where we have the most clinical experience. There's a lot of literature on utility of it. We know that from a clinical perspective, we have measurable effects from it: cognitive function, performance of functions, those kinds of things. And so NAD into the system directly, either IV or subcutaneous, is the most effective and bioavailable form of NAD. Now, there are oral forms.
I have for you, because on the oral forms, what I've read is that only like 15 to 20% actually makes it in past the digestive process. And so what I have seen recommended was doing this sublingual is a little bit better absorbed. What's your experience with that?
Yeah, so the challenges of oral administration, well, first off, the oral versions are not NAD. They're what are called NAD precursors. They're
Right.
NMR and NMN. And so they're one off from the NAD.
Yeah.
Because if you just take NAD straight, it doesn't get absorbed in the intestinal lining, so you don't get any of it. So it has to be done differently. And there's issues with bioavailability, though. So as you said, 15%, 20% at most is actually able to make it through the digestion into your system. And then it still has to be converted over and utilized. And we've had limited success with it. I think we've tried both NMN and MNR in a lot of our clients, and we're not achieving the same results with it. The other is that you have to take a lot of pills to achieve that. Now, your question about sublingual, that's always a sublingual administration bypasses the gut to a certain extent. And so because of the vascularity under our tongue, so we can get it into the bloodstream. So that's potentially a good way of doing it. I think the dosing on it a little bit, we're really not sure how much works on it. And it usually has to be in a lipophilic, a fat kind of containing formulation. I've also seen nasal spray version of it for the same idea on it.
Do you know if the nasal
and so-
spray is considered to be any more effective in terms of being absorbed by the body?
I think that because we have the vessels, the blood vessel exposure to it is reasonable. I'm just not a huge fan of, and that's something you pretty much have to do every day. So the dosing on these, whether sublingual, oral, or nasal, it's a daily thing you have to do. I'm just not a big fan on nasal sprays in general, unless you have to really do it, because we see long-term issues with the mucosa. It changes basically how that works. And it's something that I find that, again, long-term, people don't stick to it.
Yeah.
But in our experience, the subcutaneous injections once or twice a week have really been the most effective, particularly with the ability to kind of titrate the dose, as to find what dose really is optimal for people and get consistent results with it.
Do you think any benefit to maybe doing sublingual injections?
What we know from our studies of looking at NAD levels in people is we can detect when they're low. I think what we don't know is what's the optimal high levels.
Yeah.
And ultimately it would be...
Is it going to be relative? Like, is high the same for one person as it is the other, or are they generally pretty close?
It's a good question. I don't think we really know. When we do a comparison of what we think is low, we're comparing it to a cohort of teens, early 20s people. We compare almost kind of like how we do with DEXA scans and comparing bone mineral density to a population. We find a young cohort where we think, well, that's probably where it's optimal. And then we compare everybody else to that. So young normals. And so we know where your natural NAD is at potentially your optimal time in life from a metabolic kind of an aging perspective. But we don't know is more better if you raise it past a certain level, or does it just not get utilized by your metabolism?
Is there a consequence to when you stop? Do you just go back to your baseline of energy, or is there actually going to be a rebuilding period where your body has to get used to things again?
We don't see like a rebound kind of thing where people have a crash or anything after it. But I find that those who have a positive benefit from it and have been on it for a bit of time, over weeks to months of not being on it, they notice the difference.
Oh, I've
Uh,
noticed a difference pretty quickly. Does the
yeah.
body basically go back to baseline after? So,
So,
so for example, when I hear people talk about TRT, one of my concerns especially when younger people are talking to me about TRT, I go,
mhm,
you have to stay on it the rest of your life once you get on that injection cycle.
yeah.
With, you can see what I'm trying to say here, which is
Mhm.
with NAD, is it less consequential to have the injections and then you say, I can't stay on the injections?
What you're describing is kind of the feedback mechanism, right? With TRT, adding testosterone and adding exogenous, outside testosterone, shuts down any,
Yeah.
once we start replacing hormones,
Yep.
our bodies have a feedback mechanism that they understand well. And so the mechanisms that would generally force us to create our own, which are hormones that come from the pituitary gland, hormone releasing peptides that come from our brain, they basically start to shut down. If you stop these medications, you're now going to go to a lower level than where you were before you started. There can be recovery from that, but it can actually take a long time. So you are shutting down your natural processes. NAD is different. And NAD, you kind of have to think more of as like food. And that this is, NAD is part of our citric acid cycle from the perspective of that we break down fats, carbohydrates, proteins, go through a whole cellular process to make it into ATP. And the NAD basically allows you to utilize those core macronutrients down at the cellular level, and it makes it efficient. But it doesn't shut down your normal or natural ability to make it. So you would pretty much go back to the baselines of where your production level were. And that's been our experience with it. We
Yeah.
don't see people have a reversal or a deepening of their fatigue or issues without the NAD.
When you see NAD talked about online, one of the things that people, and I don't know that there's any studies or science behind this, but there are people that claim it gives you much more youthful appearance and things like that. Has that been your experience anecdotally,
Yeah,
as they call it in
anecdotally,
science? Do you have any anecdata on that?
addicted. So full disclosure, like you, I do the NAD myself. And part
Mhm.
of it for a lot of the things in the clinic here is, yeah, I'm going to be a guinea pig on all longevity
Yeah.
and all these things. Part of it too is I want to understand how they work. And if I'm going to advocate for them, I want to understand if there's side effects or there's any downside to it, what the process is. So even a lot of the development of the injection pen, it was for me. I wanted to be able to do this much more conveniently and travel with it and do all these things. Now, that being said, I would say that we have seen skin changes, people basically having a more youthful look and a lot more energy, people coming in saying they feel like they're glowing. So we do see that. The list of benefits is really long. It seems like it's a miracle drug, right? And I'm a little always cautious when I see
Yeah.
these kind of things that it's like, it's great for just about everything. And so over the years, we've looked into specifically these different areas, and a lot of things have been corroborated from studies, or we look at the mechanisms. And so there's a fair amount of validation for it being anti-inflammatory and that it works as working at the DNA level to increase DNA repair and being looked at for early dementia, Alzheimer's, Parkinson's for various reasons. So we do see that. And we get reports back from our clients of just a lot of positive effects on them. One of them that's just, this is one of the things that I notice when I do my NAD injections, I get a visual acuity that I don't have normally. The retina is a highly metabolic area, uses a lot of mitochondrial energy, as the brain does. And for whatever reason, mine really, the NAD, my visual acuity goes way up. And I've had other clients who just independently reported that to me without me prompting them.
Yeah.
The same kind of thing where now they can see and read signs when they're driving that they normally couldn't. I don't entirely understand the full mechanisms of that but it's something that is consistent. And at least for myself, it's consistent. And a lot of other energy level reporting basically of stamina and fatigue and or just how your workday goes. I have a lot of professionals. I have actually a lot of physicians who are in my practice who are not in my specialty. So they come to me for their longevity or kind of practice and their overall, I'm their primary care doc. And I hear this across the board from the docs we tend to be a little bit more critical. And they were always wondering, is this a placebo effect? Are we just basically having a very powerful placebo
That's a
effect?
pretty specific result if you didn't prompt them.
Yeah. And I find that amazing. And we've seen various other things, but along the lines of things
Yeah, and
where
by the
the
way, guess
vast majority of
that
people
effect
reported
is
it.
going to be limited to your older patients, just because generally people under 40 don't have sight issues. So I, I'm
Yeah.
generalizing, but did that what do say the people who had perfect eyesight to start with? What kind of experiences did they have with it as well?
Well, so that you kind of really hit on it in that I have this discussion with younger people who come to our clinic or who are approaching us about the NAD as to how much benefit they're going to get. So it's, I think, one of these things where if your NAD stores, your NAD levels are pretty optimum already, adding more NAD,
Hmm.
you may not notice,
Yeah.
right? So as we get older, and we start feeling these things, then yeah, that differential starts to become much more noticeable. Energy levels, stamina, just cognitive and concentrating abilities. So it is one where I was actually speaking to someone in their 20s recently, and weightlifter, bodybuilder, and interested in NAD. And it's like, well, I'm not sure you're going to get anything out of it
Yeah.
because I would hope your NAD levels are pretty optimal already. Now,
This is,
that being
by the way,
said,
it's you could use that same logic across the board for a lot of things. For example, someone in their mid 20s saying, "Should I be low carb?" Right? And they're already running 5 miles a day. I go, probably at your age and your lifestyle is probably not going to make that big a difference.
yeah,
If you're 45, diet makes a much bigger difference in terms of macros and micros and all those things. So
yeah.
just to kind of paraphrase it, if you're younger and in your prime, these things are tiny tweaks to play around with. They're not big needle changers.
And I agree. And that's for the vast majority, I think. When people encounter illnesses or viral, we see those post COVID with Lyme disease, other things, and when they're younger, that's a different story. So we know that stress due to illness or otherwise will deplete your NAD. And so there's a role for it from a clinical perspective and when you're younger. But if you're otherwise healthy, just looking at trying to maximize or optimize performance, yeah, I think there's less. Rule of thumb, my guideline on it is 35 and older. Start thinking about it and maybe staying ahead of it. I think the human body has an amazing resilience to repair up to a certain age. And once we hit that
Yeah.
35, 45, we start on the other end
Yeah.
where we have to pay attention to these things. And we can reverse a lot of negative processes that we may have encountered in our youth. I agree with you on that.
So I actually came to start really researching NAD about 8 or 9 months ago. Dr. Craig Conover did a podcast with Andrew Huberman, and it was on peptides, which is interesting, which is, you wouldn't think that that's what turned me on to NAD. But at the end of the podcast, Andrew Huberman asked him, "What do you find to be the most beneficial intervention, period?" He said, "Oh, peptides are good, but nothing comes close to injecting NAD." He said, "Nothing." Like he said, I've seen so many. This was one of the things that I found was pretty consistent, was apparently it's used a lot for addiction, like alcoholics, people who are addicted to drugs. Apparently it's one of those things that really helps people break the cycle. Have you had that experience as well?
Yeah, that's not the type of medicine I practice, but that's also where our early experience with NADIV, that's what basically we're leaning on is basically addiction medicine really had a lot of experience with it and literature on it, safety, what the protocols were. So our initial protocols actually emulated a lot what we were doing for addiction. And it's been something that's still quite used
Okay.
for it. So I would absolutely agree with that. The mechanisms by which it works, I don't know that we fully understand,
Right.
but we see very good results with that.
So let's pretend you're talking to the audience here. Who would you say would be a good candidate to researching this and maybe contacting your clinic?
So certainly anybody who has encountered any kind of chronic has been left with any residual fatigue issues, or fatigue or brain fog, whatnot, they're right off the bat a very good candidate. I think otherwise, like I said, kind of age 35, 45, when you're looking at optimizing what you're doing, optimizing your exercise routine and kind of protecting your DNA from aging, I think that's a good place to start. My clientele, everyone over 55, almost everyone's on.
Mm-hmm.
So we find kind of rare that it wouldn't be something where people are interested in and that there's not a rationale for it. I think NAD is pretty much the top of the line as far as optimizing your metabolism and health span or longevity type of molecule.
All right.
So we talked a little bit about the injection pen, and you had some other questions on that. So basically, I know for the audiences that who hasn't seen this, basically, this is what it looks like. It's essentially a dose vial that goes into a pen that has multiple doses in it. We attach a sterile needle that is a one-time use needle. If this is a 31 gauge needle, you're able to dial in
That
the
needle,
dose.
for the audience, that needle is about synonymous with a mosquito at this point. It's super
Yeah,
tiny.
and so part of the idea on this was for us to develop a system that, one, easy to use, easy for us to instruct people on how to do it remotely, sterile, which is very important, so that anytime you're doing an injection, if there's any not a sterile technique being done, you risk getting a little skin infection, which can get out of hand. So we always want to be careful with that. Easy to do. We can dial in the dose also, that if I have a client who says, hey, I've been doing 100 milligrams, which we tell them how much to dial up on here, and they're feeling like it's too much, well, we can reduce that dose. So it's just a simple conversation. We have to
So how
send a
do the
new prescription.
how do the numbers on the back relate to the amount of NAD they're getting?
Yeah. So basically, a number on here is essentially a 1 milligram, or I should say, it's 1 unit is 2 milligrams. Our concentration of what we're able to provide on here is 200 milligrams per milliliter. Okay. So that was the other component on here, is that when you're doing these injections, we want to keep the amount of material that you're injecting, particularly since it's just going under the skin, is subcutaneous, to a reasonable amount. So it's small, and we're not injecting like 2 mLs or something large like that. And a lot of the providers of NAD that are out there, that's what you have to do. You have to put 1 ml or 2 mLs in to get those kind of doses. So in order to get these doses, you got to do a lot more injections. So that was where we worked really hard to have that concentration. So 50 units on here is essentially 100 milligrams. And that's what we recommend for most people to do
50
that
twice a week.
50 twice a
Yeah.
week. And we provide 1,000 milligrams, so there's enough to do for a little bit longer or to do additional. That's not the upper limits of it. Occasionally, I will have someone who wants to do an IV version, and they need a high dose of it, but either their veins are not very good or they just really don't want to do an IV. And we'll do what we call a short course of high dose or high intensity on the pen and have people do it every day.
So if I'm training for a marathon, okay, so when you're training for a marathon, you'll have a couple of, say, 20-mile runs, and then you have the race. What if you were looking at my training schedule, when would you tell someone like that, hey, you need the ideal time for you to do a higher dose? It'd be pre-big run, post-big run?
Basically, a competitive event. This is also the I give to my pre-surgical patients before they're going in for surgery, chemotherapy. We intensify the dosing to boost up 500 milligrams the week before. Then not immediately after, you need a little bit of a few hours after completing the whatever that challenge, the NAD, usually 100 milligrams, and depending on basically how fatigued you are from that, potentially milligrams afterwards. So it's 5 before, 5 after is kind of an boosting protocol.
And I apologize, I don't know the name of that pen. I would call it something like Dial-A-Dose.
Easy Pen. We call it Easy Pen.
Easy Pen / Dial-A-Dose. What would that number be for people?
So it would be doing 50 units.
They would set it to 1 for that?
No, so they would still send it to 50. And so you're doing 100 milligrams. Remember, it's 2 milligrams per unit.
Okay.
So it's 100 milligrams or 50 units, and they would do 5 separate injections, 1 a day for 5 days.
Okay, I got it.
Now, you could go higher, but for the same issues we have with IV, you start getting really high doses. Say you do multiple injections of the NAD in a really short period of time, like back to back, you're going to have side effects from the NAD. And they're short term. You get over them. They're not harmful, but they're annoying. You can get some kind of a flushing, that same kind of thing that happens with niacin. There can be some gastrointestinal issues. People can feel nauseated and get a headache. A very high dose, very quick of NAD, people will get a feeling of chest pressure. And it's not actually cardiovascular, it's not pulmonary, it's a vagus nerve response to that, or persantine response.
So there's a diminishing point of return there where you go, you're going to need to weigh this out to your particular need past a certain point. I mean, as someone who's been an athlete for a while, you think about having a cup of coffee before a race is a very good idea. Having 2 cups of coffee, you're starting to get into you might get into GI distress. You might get the
Mhm.
jitters, might have a crash mid-race. So just knowing that effective dose to give you sort of like the optimal performance and recovery.
Absolutely. The dose is important. And the guidelines I just gave you, that's worked for a lot of people, but you have to titrate it. I have other folks who are very, very sensitive to this and that we reduce their dose. And that's, I think, part of with what we do that differentiates just we're a full-on clinic. We deal with our clients every day and we're very passionate about these things. And we support everybody on the other end of this. So there's a clinical team behind it. So when questions like this come up, I'm about to do this, or I'm going to have this surgery, or I'm going to do this event, guidelines or advice on how do we increase, decrease, optimize the NAD. And for us, that's part of what we do as part of our support program with the NAD.
So what interventions and or supplements have you found to be complementary towards taking NAD?
Well, interestingly, we do a lot of work with GLP-1 medications as well. I mean, I'm also board certified in bariatrics and obesity medicine, and that's a peptide that we've used for a long time. NAD pairs extremely well with the GLP-1 medications. There's a fatigue, particularly when people are getting a little bit more calorie deficit.
Mhm.
Adding NAD has been extremely helpful and has made all the difference for certain people. So that one which is quite popular.
Yeah.
So we're doing a lot of GLP plus NAD. Otherwise, I think we look at, from our clientele, we look at overall their whole health system and as far as what other nutrients are important for them. And it's an individualized kind of assessment on it. There's no real contraindications that we have. We've never really run into any kind of herb or drug interactions with it. But I would say I'm a little bit more cautious of people who are on a lot of antihypertensives who might be occasionally running low in blood pressure with NAD, just because we do sometimes get a blood pressure effect, a little bit of lowering blood pressure, which is good for most people.
Okay. All right. So any other interventions, whether it's supplements or otherwise, that you've been kind of bullish on lately, like the science and research has been, I'm not asking you, I'm curious as to what's intrigued you lately.
Yeah. GLP, whole area beyond weight loss, it's also very intriguing. There's lots of other mechanisms that we're seeing for anti-cancer, anti-inflammation, rising up to the top of the shelf from a longevity perspective. So
Mhm.
where it's appropriate, it's something that I've been watched that. Do a lot of work also with rapamycin, with low-dose naltrexone, with
Yeah.
metformin, and we have a good history with those. And those, I think, are things that before we really started using NAD, I think we used a lot more of them from a longevity perspective, but
Y-
they require a much more individualized approach because
Yeah,
we're,
I've kind of looked into the rapamycin and metformin for a few years. I've never tried it. My caution with it was, and I apologize which one it is, but they're often used for diabetes, right? So,
yeah,
yeah, metformin. And so for someone who's super active and training a lot, it actually works against you in the sense that your blood sugar, it lowers your blood sugar, which with your training.
yeah. So, yeah, so that's a important thing to understand with these is that, well, if you're pre-diabetic or if you're a little bit insulin sensitivity issues, so insulin insensitive, metformin has a role in improving your glucose metabolism and improving all of that. But if it is normal, are you getting the same benefits from it? Metformin's an AMPK inhibitor, which is part of why we think it has some longevity components to it, has some anti-cancer activity to it. Inexpensive, very well tolerated. So it's something that I think is going to remain on the radar as being investigated
Yeah.
as potentially a geroprotective. And we'll continue to watch that. I think the GLP-1 medications are going to replace some of that space. Rapamycin is interesting from the perspective is that loads of data on it from a anti-aging or a longevity perspective. I think the data that I see on it, pretty much every organism for which rapamycin has been tested on has demonstrated a longevity result, except for in people, just because the studies can't be done. We can test
Yes.
on everything else. The challenge I have with it is high doses of rapamycin, what it is clinically indicated for is an immunosuppressant. We use it for transplant to
Yeah.
patients to dampen the immune system so we're not having an auto reaction to or a transplant rejection. And the way we're using it for optimizing health is in low dose. And I think we're getting better at understanding what that regimen should be, what that sequence should be. But until recently, it was kind of all over the map. And I think we're starting to see people settle into low dose once a week kinds of regimens. But I have had clients who have been on it who developed lipemic issues. So their cholesterol, triglycerides started to rise, or their glucose basically started to rise. And we started to measure them having essentially prediabetes, for which then we managed their cholesterol either naturally or with statins, or we managed their sugar with metformin. And when I look at if we're trying to use a medication for longevity, that then I have to use potentially 1 or 2 additional medications to counter the potential side effects, it starts making less sense to me. So I have a little bit of a challenge with that.
To a credit card comes a bit of a balancing act there. Cholesterol. I know we're running short on time here, but I want to ask, because this was one of my favorite takeaways from Peter Attia's book, was he focused on the APOB. Have you had any insight? Whenever I ask about APOB, the only thing I ever hear is to take a preventive statin. Have you had any insights as to things you can do to control APOB?
Yeah. So, I mean, I'm not opposed to statins. I think they're okay for the right people, and if you're not having side effects. I do like using natural statins if we can. So reduce rice in combination with things like beta-sitosterol and going that route, see if we can control that. But it is a challenge when we see that we know that basically diet, exercise, and other things don't really have an impact on apolipoprotein B, right? And we know that that's one of the atherosclerotic, atherogenic components of cholesterol, right? So it's one there's a balancing act on whether I think I would prescribe a statin just to maintain that or manage that in isolation.
What would be the precursor? And you say you were talking about red yeast rice, and I didn't get what the combination would be there. What would be the sort of like first line of defense?
Well, red yeast rice and beta-sitosterol basically help control cholesterol levels. Red yeast rice is essentially a natural statin.
Yes.
So
now I didn't know that. I didn't know the
activity
other one you mentioned.
Beta-sitosterol acts a little bit more as a cholesterol blocker for intestinal absorption. Pretty good combination, I believe. So that's for my practice, that's usually where I start. But I think I look at the overall cardiovascular risk and profile of someone. So we're going to see what their cholesterol levels are. We're going to make sure they've optimized their nutrition, that they're exercising. We'll do a little bit more intensive study of their cardiovascular system, coronary artery CT, stress testing, and just understand where people are. And we're going to maximize lifestyle interventions first. And despite that, occasionally we run into someone, they're doing everything right. And they've got a genetic cholesterol profile that is not great. And we know that they run the risk basically of developing atherosclerotic disease, which is still our number one, particularly for men, is still our number one way we go out.
Yeah.
And so it's worth addressing from that perspective. And even from the way we run is like, well, we have our standard of care recommendations for kind of how we titrate or how we tier different cholesterol for different levels, to implement as many complementary methods, lifestyle methods first, so that we can use low dose statins. We keep the level of medications down to a minimum.
Yeah. Okay. So the takeaway there is try the red yeast rice, and there's the
Beta-sitosterol. There's a couple of different products out there. If you look at the herbal products out there or the supplement products, but you'll see that as a combination.
I'm just trying to steer people off the snake oil. That's all.
Yeah.
Obviously, you're saying dose up the statin only to the point where it's beneficial and no more.
Yeah. I mean, so I think statins kind of get a bad rap, or I shouldn't say get a bad rap. We, in our healthcare system, we know statins work. I don't dismiss the evidence that we have direct correlation between improving cardiovascular outcomes, mortality from cardiovascular events, and statins. There's a pretty good relationship with that. But I think overall in our healthcare system, we don't basically address any of the other underlying, well, how did you get there? Nutritional patterns, basically fitness have a huge aspect to these. And so we're maybe a little too quick to go to a statin without addressing those other issues.
Yeah.
So for us, we reverse that. Statins is my last thing to add on after we've really been pretty aggressive at all those other things. And so when we do that, we find that, I just generally don't need to be on a high dose regimen.
Dr. Fabio, you are a wealth of wisdom, and I'm truly grateful for not just coming on the podcast, but for what you've been doing for people, I found your practice through AI. I was asking AI a lot of questions, and you came up as one of the recommended people I should talk to. So thank you for all you're doing to help people enjoy their lives and live more fulfilling lives. We grew up, we're probably similar to the same generation. I'm 48, but
I'm 60.
yeah,
So
I need to copy your reg.
we're
But
timeline.
but you'll
Yeah.
agree with me here. We grew up with this idea that once you're over 40, you start hanging things up, and then by the time you're 67, you're pretty much relegated to the house. The big travel plans are gone at that point. And I think a lot of us are really trying to question that and kind of say, I don't have to submit to that. That doesn't have to be the case. So I really appreciate you bringing this type of information and giving people options to say, it doesn't you don't have to sunset your life just because of a particular number.
Absolutely. I mean, the whole concept of what we're doing, I absolutely agree with you. And I'll be honest with you, I'm just getting started.
Yeah.
I've done a lot in my career, moved around a little bit within this kind of space, but I'm not ready to hang it up even close.
Oh, you're in.
And so then that's part of it. Yeah, looking at all of the things that you can do that are in your control to improve that health. Tomorrow's promised to no one, and things happen. We have issues that aneurysms, cancer, the kind of things we want to try to avoid. But part of it is making sure we take care of those things that we can, but that we're not creating an environment in our bodies such that we're promoting aging and we're promoting chronic disease and those kinds of things. So yeah, for us, it's about living a long life, a functional life, and potentially then you just hit a cliff. When it's time, you're not lingering 10 or 15 years with debilitating chronic disease. Our healthcare system is really good at keeping you going, but not really making your life enjoyable. So
No,
that's
that was
kind of
one
our thought process.
I don't know if you've seen this data, but the blue zones and some of these other zones, what they found was they had, say, a heart attack or something like their lifespan was very similar to basically the standard American person after that event. But they were just so much better at preventing that event from occurring in the first place. I think
Absolutely.
that's part of what this whole preventive medicine is about, is saying give yourself, you can bookmark the odds in your favor to put those type of events, push them 10 to 15 years out because of lifestyle changes. Not to say you can prevent them, but you can basically.
Yeah.
And again, we're not necessarily interested. I hope I don't butcher the phrase, but there was a runner's phrase that I always cling to when I was a competitive athlete, and it was, I'm not running to add more years to my life, but more life to my years. So I think about that when we have these conversations, because what we're trying to do is we're not just sitting here saying, maybe you'll live 5 more years. We're trying to say you can enjoy that time so much more and have a much
I
more
think
fulfillment.
that is a first off, that phrase you just used, it's actually practically on my business card. Adding life to your years rather than years to your life. Now, we optimally do both, right? But years to your life without life to your years, I don't think is a really good goal. It is what we have discussions with our clients and understanding their goals all the time. This comes up with our cancer patients quite a bit because we potentially, if they've got a stage 4 cancer, we know we're not going to beat it. What's your choice? We can try to maximize your time, which means we might subject you to some pretty significant and very morbid procedures, chemotherapy, whatnot, or we maximize your enjoyment, which means your ability to travel, your ability to be with family. And again, trying to optimize both of those, but sometimes it's just really an honest conversation of where are we going to focus? And invariably, I find that people basically want to have life in their years, not years of extra life. I think it just makes a lot more sense. So absolutely agree with you. And we continue to strive and look at different mechanisms for that. Now, with my background in culinary medicine, blue zones, Mediterranean style, anti-inflammatory eating, we're all over that. That's a huge area that we spend time teaching our clients. We have a teaching kitchen. We teach people to cook, and we talk about this. We've been fortunate to have met with Dan, who's the founder of that, to the National Geographic. He's a wealth of information and potentially a topic for discussion if we want to dive a little bit deeper in that of another talk. It's one where dietary patterns come up, passions on it, where people come into the conversation. Unlike NAD, if you're not familiar with it, we got the science, we have some history on it, but you're coming from an area of not knowing a whole lot. Everybody eats probably a couple times a day. Everybody's a little bit of an expert. So it's one of those things that can be a little bit more challenging for folks to digest.
Absolutely. Nope.
Yes.
Well, this has been wonderful, Dr. Fabio. Thank you so
yeah.
much. Please tell people where they can find you and your practice.
Yeah, for general understanding of what we do, drfabio.com, so drfabio.com is our main website. There's information on there about NAD, but in particular for those who just want to really focus on the NAD, we created a separate website. It's called NAD Easy Pen, so NAD Easy PEN, and that'll guide people through how to get started with it. For the most part, I like people to do their due diligence, understand a little bit what they're getting into and what to expect. As part of our process, we do a little bit of an intake. So there's a place for people to register and give us a little health history. We look at that, make sure it's appropriate. And if somebody goes through that and submits it, we reach out to them to provide the NAD. And you
Wonderful.
did ask about cost. We mentioned what the IVs cost. For our program, essentially it's $235 per month for 1,000 milligrams. We do charge for shipping. We're trying to mitigate that a little bit more for our clients. But, we try to make it as reasonable and sustainable for folks from a pricing perspective.
That's all right. Thank you so much.
All right. Well, I appreciate you having me on your program and look forward to speaking to you soon again.
Thank you, Dr. Bob.